pregnant, a lot of pieces will have to align almost perfectly. And unfortunately, human reproduction is generally inefficient. And even at its best, for couples with normal fertility, the chances every month are about 15%. That's 15%, not 50% per cycle. And if you think about it, really, the stars have to align. The egg is really only fertilizable for a very small window of time, and sperm around that time that egg is being released in order for fertilization to happen. And then from there, that fertilized egg has to develop into embryo, and then that healthy embryo has to make that long journey through the tube into the uterus and implant. So lots of things have to happen for pregnancy to occur. And there are some simple things that you can do to try to improve your chances of getting pregnant naturally. My number one recommendation is to use an ovulation predictor kit. And if we can do it, a great one to use is really a digital kit. So Clear Blue Easy, I'm not affiliated with Clear Blue Easy, but Clear Blue Easy is a great kit. They have a couple of different options. Is with the regular kit that basically just tells you when are you surging. And then there's an advanced kit that measures two hormones, not hormone, but it also measures estrogen. So it gives you even a longer warning that ovulation is going to happen soon. And so how the is that they basically detect the hormone luteinizing hormone. This is the hormone that rises just before ovulation. And for the women, when you get that positive surge, you'll ovulate somewhere around 24 to 36 hours later. However, ovulation might happen for a small number of women up to 96 hours after a surge is detected. So when should you try you get a positive surge? Best advice is the day that you get that peak fertility. So when you detect that surge, then the day after. Those 3 days of trying in that window will hopefully give you the best chances to conceive. Beyond using an ovulation predictor kit, other things to keep in mind are just, from a lifestyle perspective, to keep our bodies healthy and ready for a pregnancy. Taking a prenatal vitamin is really great, and starting the habit before we are pregnant is a great ritual to kind of keep in our routine, so that when we're pregnant, it's almost like it's not something atypical that we would be doing every day. And then beyond that, if you smoke, best advice is to do and make every effort to try to quit. And the reason for this, that, beyond all of the other things that we know smoking can increase the risks for heart disease, risk for many different types, risk for lung disease, smoking can actually also significantly affect your fertility. For women, there have been studies that have shown that smoke may go through menopause at an earlier age. And on average, smokers can go through menopause 1 to 4 years earlier than what we would expect based on their ethnicity. And this is really important because the end of a woman's fertility is roughly a decade before she goes. So if we're doing something that would advance that age of menopause, we're also then doing something that would advance that age that we would experience at the end of. Beyond that, alcohol. In general, especially in pregnancy, there's no safe amount of alcohol that you can drink. So in pregnancy, for sure, we recommend that we should not drink alcohol. But what about trying to conceive? The best data that we have is really evaluating alcohol as it relates to outcomes with fertility treatment, and even more specifically, really with IV. And generally what we recommend is 4 or fewer drinks a week while we're trying to conceive. If we're able to abstain after ovulation, but sometimes, we might have a glass of wine and we didn't know that we were pregnant and we get that positive pregnancy. Best thing, once you get that positive pregnancy test, we eliminate alcohol from the diet. And then lastly, caffeine. Coffee, I need a cup every morning, but high levels of caffeine in our diet can be associated with miscarriage. And number here is about 200 milligrams. And our average cup of 6 to 8 ounce cup of coffee not a Starbucks or a blonde brew, dark brew. Average cup of coffee has somewhere between 60 to 80 milligrams. So best advice here is to drink no more than 2 8-ounce cups of coffee a day. And then beyond that, everything that we do today to keep ourselves healthy, whether that's dietary or that's exercise, can only help to improve the chance of conception, can only help to improve responsiveness to fertility treatment, and then can only really help to improve maintaining and continuing pregnancy. So minimizing processed foods while we're trying to get pregnant is great. A really great marker for type we should stick with, and those we should avoid, is something called a glycemic index. Glycemic index is basically a measure of how your body reacts or load. And so an example is if we're drinking a can of Coke, glycemic index is really high. And the glycemic index, basically that's telling us that our body has to work really hard. Our pancreas, that special gland that makes insulin, has to work really hard and lower sugar levels in the bloodstream. And over time, the harder our body and our pancreas has to work, the higher chances for things like diabetes. From a metabolic, it's great to have diet enriched with low glycemic index foods. But from a fertility standpoint, the same is also true. Although there's not been, a specific diet that has been shown to increase the chances for getting pregnant naturally, in general, I believe that it might look something like a Mediterranean diet. So a diet that's full of really healthy fats, a diet that's full of vegetables and whole grains. Hopefully with these tools preconceptionally, we are optimizing our health, not just to get pregnant, but to have a healthy pregnancy. Another really common question that we get often is what other tips might we recommend to improve the chances every month, aside from those ovulation, would having intercourse multiple times a day increase the chances? Is there a certain position that might increase the and in general, guys, the rule of thumb is as long as we are having intercourse once a day during that ovulatory window, peak time that month that we're identifying with that ovulation predictor kit, really once a day for those 3 days is really sufficient. Times during a day doesn't seem to increase the chances beyond that one time a day in that very specific window. So let's say we've been trying for 6 months if we're over 35, or we've been trying for more than 35. What do we do then? As I mentioned before, the next best step would be to talk to your OB or to maybe even talk to a fertility specialist to try to understand where you go. At that time, what's typically recommended is an evaluation. And from there, the evaluation shows considering some type of treatment. And the goal for treatment is really to shorten to that pregnancy. Because as women, what we battle, unfortunately, is as we get older, the number of eggs that we have declines, and after, it just becomes more difficult to conceive. So the goal of fertility treatment is to shorten that timeline, to get to that conception, take advantage of the reproductive window, of an individual's reproductive window at that moment. What's involved in an evaluation? There's typically 4 things that we look at. The first thing that we typically look at is something called ovarian reserve. And ovarian reserve is a group of tests. So it's not just any one test, but a group of tests that really tell us how ovaries would respond to fertility treatments. And that's really important because ovarian reserve doesn't tell us anything about the likelihood of pregnancy, natural pregnancy, or whether that's a pregnancy that could result from fertility treatment. It merely tells a fertility provider, would those ovaries respond? And so what do we mean by response? Every month, naturally, if you're ovulating, your body is recruiting somewhere between 2 to 3 eggs, 1, 2, or 3 eggs. When we're doing fertility treatment, and even more specifically, when we're doing IVF, the goal with the injections, more eggs to grow than what your body is capable of doing just with a natural cycle. And so ovarian reserve tells us that we would be able to do that. If the reserve is normal or what we would expect for age, then great. Exposing you to these injections, that we can get more eggs to grow and perhaps make embryos and hopefully a pregnancy thereafter. When reserve is low, what that might suggest is that the treatments that we use for IVF, the medications, the injections, maybe they aren't the route for family building, as they are unlikely to maybe increase the chances beyond what you're capable of already doing naturally. There's kind of another way to look at ovarian reserve, however. Now, we don't have a lot of data about, what these levels typically look for women individually outside of a diagnosis of fertility, but we have some data. So we have some data about really where these levels should be based on age. And so another way to look at ovarian reserve is, where do you fall compared to other women of a similar age? All we can kind of tell from this test, however, is fertility treatment. We can't really predict when or if that number will change. So for some women, it will for quite a period of time. And then for others, especially as we get older, there's a much quicker rate of change. And so it's something that we would continue to follow through treatment until we're pregnant. The second thing that we look at is other hormones. So we look at thyroid function for everybody who is coming for a fertility evaluation. But then there are other hormones that a fertility doctor or your OBGYN might recommend checking their history. So if you have irregular periods, we should be evaluating not just thyroid function, which can cause that irregularity, but like prolactin, which is the hormone that women typically make during breastfeeding, but it can be spuriously elevated, sometimes from the macroadenoma, which is a benign tumor in the pituitary gland, which is also the gland that is the source of follicle-stimulating hormone that recruits eggs. There's another very common condition, and probably the most common condition that irregular periods in reproductive age women, that's polycystic ovary syndrome. In order to be able to give a diagnosis of PCOS, you have to everything else. So it is a diagnosis of exclusion. And then you also have to meet 2 of 3 criteria, like irregular period, evidence of elevated male hormone, whether that's clinically or with a blood test, and evidence of polycystic appearing ultrasound. So depending on your clinical history, your doctor might recommend testing male hormone levels along with might recommend testing prolactin levels along with the thyroid function, and maybe just checking your serum progesterone the cycle if it's unclear whether or not you're truly ovulating. The third thing that we look at is really anatomy. So this is an assessment. Of course, we need to have at least one tube open for that egg and sperm to meet to make an embryo, and for that embryo then to make it to the uterus. There are a couple of ways that we can look at tubes. By and large, most fertility providers are moving towards office assessment of tubes, and that's with a procedure called a FemViews on a histogram, or another common term is a saline infusiogram. So the procedure, and it is a procedure, it is a minimally invasive procedure, doesn't require anesthesia. It starts with a speculum, we put a very small catheter into the uterus. We fill the uterus with water, and that water has some air bubbles in it. And the cool thing, ultrasound, we can follow those air bubbles because they show up as bright white spots on ultrasound. And we follow those air bubbles into the uterus and then hopefully tubes. So we get an assessment not just of what does the uterus look like, but we get a nice assessment of, do we have at least one tube open? Certainly, if we don't confirm tubal patency, this could be one of the factors for that fertility. And the final piece of the puzzle, we will never ever forget about the very important contribution partners make, but the final piece of the puzzle is the sperm. And so for this, we're doing a semen analysis. And similar to ovarian reserve testing, analyses don't tell us anything about the likelihood of getting pregnant. They merely tell us, do we have sperm? And treatment should we be using to get the sperm as close to the egg as possible? So we can utilize what we see on that semen analysis to help us, should we be doing insemination, or should we be putting the sperm a little closer to the egg and doing IVF? A lot of times, semen analysis might uncover something that needs to be evaluated by a urologist or by a urologic fertilist. Examples would be inflammation in the prostate gland that can lead to us seeing white blood cell in the semen. So there can be some benefit of doing a semen analysis even beyond what we might use the results for from a fertility treatment standpoint. And then from there, once we get all of these pieces of the puzzle together, the step is really putting them together and figuring out what is the best option for treatment. And so your fertility provider is very thoughtful about what the next best step would be in order to raise the chances for getting pregnant, shorten that time to beyond what might be the case naturally. So I'm definitely not, most fertility providers will throw out a lot of numbers and statistics, but for couples, a completely normal evaluation. So for couples that we check the reserve, we check the hormones, we check the tubes, we check the sperm, and we give probably the most frustrating diagnosis, which is unexplained subfertility. We can't tell you why it hasn't happened, but it's really important to remember that, our testing is great, but it doesn't tell us everything. The testing is telling respond to fertility injections. Do we have any significant endocrine barriers or hormone barriers? Do we have at least a path to get to the egg and then for that embryo to get into the uterus? Do we have sperm? But there's a lot of things that testing misses. What's egg quality looking like? What is sperm quality looking like? Can the sperm actually make that long egg, penetrate that egg, fertilize that egg? Will that fertilized egg develop into a healthy embryo? And then perhaps still the biggest, regardless of the treatment that we use, will that healthy embryo ultimately implant, thrive, and grow in the uterus? So there's a big part of just can't fully understand or can't evaluate with our conventional testing. And that is because then the following numbers might make be a little bit more palatable. So for couples naturally, after about a year of trying, so actually one step before this, couples with normal natural fertility, around 50 to 60% of couples with normal natural fertility conceive in the first 3 to 4 months of trying, about 70% at the end of 6 months of trying, and about 80% at the end of the first year of trying. After the first year of trying, the chances to conceive in a month go from that 15%, that 15% that we had mentioned earlier, to roughly 3 to 5%. And even if we do the evaluation and the evaluation comes back as being totally normal, the chances for natural 3 to 5%. So our goal here is to increase the chances back to maybe what they would have looked like that first year of trying. The most conservative option for couples with unexplained subfertility, meaning all the testing is normal, and they're under 38 years old, find the fertility pill Clomid with an intrauterine insemination. So Clomid is a fertility pill that's been along for a very long time history. It was initially used for breast cancer patients to cause hormone ablation or estrogen levels to prevent recurrence after breast cancer patients had chemotherapy. And what doctors found was that these women, this Clomid medication, to make their estrogen levels go down, they were ovulating and having many follicles grow. That really parlayed the use of this medication to fertility treatment. It's the most commonly used fertility pill and one that we have many decades of experience with. The newer kid on the block is the fertility pill letrozole, and that is the preferred fertility pill for women with ovary syndrome, or perhaps even for women who may have higher risks with treatment if estrogen levels get too high. But the sense of fertility pills is it increases your brain's drive to make more eggs grow. And at some point of a mature follicle, your fertility provider will either trigger ovulation, and we can do that with a one-time injectable medication. And a couple days later, you and your partner come back in for an intrauterine insemination. What that's like is it's actually not too dissimilar from the tubal evaluation procedure that we do in office as part of the getting ready for treatment. It is not as uncomfortable. Basically, what an insemination would involve is a speculum exam. Your partner or donor sperm is being prepared for that insemination. So we're prepping the sperm to breed, get rid of the not so strong swimmers and concentrating the best, highest quality swimmers, putting it in a syringe, attaching it to a catheter, that catheter into the uterus, injecting that, the best of the best swimmers directly into the uterus. And what that effectively does is a few things. Most conservative treatment. Maybe we get more than 1 or 2 eggs to grow. We usually don't want to see any more than 3 or 4 grow when we're doing because then we have elevated risks of multiple pregnancy, which is something certainly we'd like to avoid. The second thing that it does is it maximizes timing. So we're identifying the optimal window using a trigger injection or with blood work, ultrasound, monitoring when that egg will be ready. So we're narrowing down the window to expose you to sperm. Third thing that this treatment does is it puts that sperm just a little bit closer to the egg. So avoids the cervical mucus, avoids the cervix, just closer to that egg that had been ovulated. Couples that typically will get pregnant with this have unexplained infertility. Usually it happens within the first 3 or 4 attempts. And so if we're not pregnant in the first attempts, then it's usually a good idea to graduate to something else. And that's something else in the setting of unexplained subfertility is IVF. The reason for this is, like we had discussed before, fertility testing is great. It tells us a lot. It doesn't tell everything. And so if conservative treatments are not successful, it's best to move to a treatment that maybe we can get some more information about why insemination wasn't successful. And that really can only be accomplished with IVF. We get information about what eating like. We can actually put the egg directly with the sperm so we can aid in fertilization. We're watching these fertilized eggs grow into healthy, and we're timing actually putting this embryo back into the uterus. So in a lot of ways, IVF can be not just therapeutic, but also diagnostic. Now, if any of the other testing revealed something more significant as the contributing factor, so we have a lower sperm, or we have blocked tubes, or really if we have multi-factor subfertility, then usually my recommendation is to consider, as it is the only treatment that can address more than one factor. And then the in-between fertility pills and IVF is injectables and insemination. By and large, many fertility providers are moving this treatment with the exception of 2 populations of patients. The first is for women who require the eggs to make eggs grow, mostly because perhaps they are not producing the hormones that make eggs grow naturally. An example of a woman that might benefit from injections is a woman with hypothalamic amenorrhea, which periods because the normal hormones that drive ovulation in an egg to be recruited are just absent. Another might be a woman who has decreased ovarian reserve for whom IVF wasn't previously successful or successful in getting more eggs to grow than what we would accomplish already with insemination or trying naturally. And then beyond unexplained infertility and what that journey looks like. Certainly if it's just ovulation, we can correct fertility pills. If maybe it is something related to ejaculatory dysfunction or an ejaculatory disorder, maybe we can just put sperm to the uterus and time it with a natural cycle. And as mentioned before, any multi-factology for subfertility really warrants a treatment like IVF. Along with treatment, most couples want to know, what can I do to make treatment more successful? And it's always a great question. And beyond the things that we can do to maintain a healthy lifestyle, eating well, exercise, not smoking, reducing caffeine, limiting alcohol, a really popular thing to investigate is the utility or utilization of vitamins and supplements. And there's not a whole lot of literature about the use of vitamins, but there are 3 that the literature again and again, maybe there is some benefit here in regards to how ovaries would respond to fertility treatments, and then just having kind of biologic plausibility that they could improve the health of the egg, although that is from a disclaimer standpoint, I don't typically recommend, vitamins to improve egg quality. Age is this important predictor of things like egg quality. But if we wanted to use some supplements or vitamins to aid, go alongside our typical fertility treatments, the 3 I typically recommend is CoQ10. Both eggs and sperm actually have CoQ10. It is an antioxidant, and gametes, eggs and sperm, they thrive on antioxidants. In fact, for men specifically, the randomized control trials that showed that men that took CoQ10, coenzyme Q10, for 3 months, if we look at their seminal before and after taking the supplement, all of the seminal parameters, so globally, the parameters improved after being exposed to some antioxidant. Another really great antioxidant is vitamin D. And the reason I think vitamin D is great is because it's not just good from standpoint. So it has been studied in our IVF literature to show that it can be associated with responsiveness to fertility injections, again, antioxidant, but it's also really great from a general medical health standpoint. It's been shown to help reduce risk for things like heart disease, metabolic diseases like diabetes. So knowing that, what is your vitamin D status? Are you replete, you have normal levels? Are you insufficient? Are the levels kind of borderline? Are you really deficient? Are the levels really low? Your doctor will recommend bringing your vitamin D back up to normal with vitamin D supplementation. And living in Chicago, it is very common for many of the couples that I work with to be vitamin D insufficient or honestly even deficient. So it's something actually I check before we start IVF. And then the last is a fish oil. So taking 1,000 milligrams of omega-3 fatty acids has also been shown to be a very effective antioxidant for egg health. So beyond that, guys, honestly, there's not a lot of data about supplements because supplements typically are not FDA approved. They are not studied by the literature. And so we just don't know how these supplements interact with one another, whether or not they truly improve outcomes, and whether or not they could interact with other medications that you might be on from a fertility treatment standpoint. So outside of these, I typically recommend talking to your provider, your OBGYN, your fertility specialist to go with other supplements you might want to take. There is one exception. I forgot to mention a 4th supplement that I now am recommending with polycystic ovary syndrome, myo-inositol. So myo-inositol is a kind of newer kid on the block. Specifically for PCOS, it might help to reduce the chances for the metabolic disturbances, so diabetes, lipid abnormalities, cholesterol abnormalities with PCOS, and perhaps it's also good for egg health as well. Acupuncture is another therapy that I think is really great, and it has been studied quite a bit in regards to fertility and fertility. The best studies for acupuncture and fertility treatments, namely IVF, the best studies, though they haven't shown that the use of acupuncture increased the chances for live birth, two things are really clear. The first is that acupuncture reduces stress. And it is really to experience stress as you're starting the journey of fertility treatments, as you're facing a diagnosis, stress is very normal. And so far as we know, stress by itself doesn't to cause subfertility or infertility, but stress might make fertility treatments less successful. It might be attributed to retention. If we're feeling overwhelmed by what we're going through, maybe we're more likely to say, hey, this isn't for me, I continue with fertility treatment. So anything that we can do to minimize stress is not only going to keep you on that path to that ultimate final goal, but maybe it might make fertility treatment more successful as well. So I think acupuncture is great, and certainly talk about it with many of the couples that I work with. Many of the couples that I work with bring it up as well in that first consult. Any makes you feel good and centered through a very stressful time, I say go for it. And, from there, beyond supplements and acupuncture, any other therapy that you're thinking about, I think it's always just really great to touch base with your provider or your OBGYN to see what recommended. A few more questions that we got more recently about fertility, and actually a good segue into stress is really how infertility affects women or family psychologically. And it's definitely clear that receiving a diagnosis of infertility can be it can shake your world, and it can definitely, rock the relationship as well. And some have equated this and struggle that a woman or man might experience with that diagnosis as being similar to the stress and struggle that you might experience when receiving a diagnosis of cancer. And that's very, so infertility is a medical condition. It is a medical diagnosis. And, unfortunately, it's a diagnosis that carries a lot of weight emotionally. I think it's always really important for any journey, whether you're in the beginning, you're in the middle, you're in the end, or you're getting ready to start again, to always check in with yourself, check in with and I always tell my patients, check in with me. Let me be the person, let your coordinator be the person that you touch base with. As much as we can, be open and honest with how you're feeling, because we know that it is a very uncertain time. It can be going through fertility treatments can be an investment emotionally, physically, and as well. And it's an investment in your relationship. So the more that we can support you, the more that you can support yourself, and finding is really important. And that's another part of being a fertility doctor that I love, is that I think that there's just an incredible for anybody that has gone through fertility treatments or will go through fertility treatments. It's really amazing. I think the best way to support families dealing with subfertility is to listen. Had 2 cycles of IVF myself, and having 2 babies, thankfully, luckily, from the treatment that I underwent, looking for anyone to give me advice. I think even if I wasn't a fertility provider, I just wanted my friends to listen. I wanted my sister to listen when I was struggling or having an emotional day from whatever news I might have received as a result from my treatment. And so I think the most important thing is just being there as a shoulder to lean on, to listen. No advice needed, no words need to be said. And it felt really good too to have friends just send a text and say, hey, how are you doing? How is this other thing in your life going? Bringing the focus away from the fertility treatment, but still connecting and touching base and letting me know that they were there for me and me without directly maybe referencing what my husband and I were going through at the time. And I thought that was always great to have day to day. And we received was, what does fertility look like after a cancer diagnosis? And it varies. It varies for the individual. And the reason for this is that the impact of cancer treatment on men or even a man's fertility is dependent on the type of cancer treatment that was needed, the medications that were required, the number of cycles, and then also the age at which you're receiving these. So we do know that chemotherapy can affect, let's say specifically for women, chemotherapy can affect the pool of eggs that we have. And we don't have a lot of data about pregnancy rates, fertility rates, live birth rates after chemotherapy, but what we do have is, what is the chance after you receive a chemotherapy regimen, what is the chance that you will stop having period? And so we call this the chemotherapy-induced amenorrhea rate, or the CIA rate. And this is important because if periods after you have had chemotherapy, we would maybe equate this to, is it possible that this treatment threw your ovaries into an earlier than expected age at menopause? But if you have periods again after therapy, the tricky part about this is the resumption of periods doesn't necessarily mean that fertility has been. In fact, if we look at women that resume cycles after being exposed to chemo, we still can see, higher chance of fertility and potentially even an earlier age at menopause. And again, the importance of that is that if menopause is coming a little bit earlier, then end of fertility could come a little earlier as well. So what's recommended by the for gynecologic oncologists, the American Society for Cancer Oncologists, is that for any individual, man, even child, that is facing a treatment that could render them infertile in the future, that they seek a consultation with a fertility specialist to talk about fertility-preserving procedures. For women, the gold standard fertility-preserving procedure is egg or embryo freezing. Are some experimental options like an injectable medication that can essentially put you in a prepubertal state and maybe protect. That's experimental but still offered. For men, it is, and another experimental option for women is actually doing a surgery and freezing ovarian tissue. That's called ovarian tissue cryopreservation. That's the option that is typically recommended for premenarche or prepubescent women. For men, it's freezing sperm, and for pre-boys, it's testicular tissue cryopreservation, which is the more experimental option. So it's really to talk to a fertility provider before starting any cancer treatment to go through what are your options, but then beyond that, to really talk about what your treatment might, what impact your specific treatment might have on your future fertility. So if we freeze sperm, let's say for that man who was facing cancer treatment that could have really affected or those stem cells in the testicles that make sperm, what is the likelihood that we can get pregnant? IVF with frozen sperm, the actually not significantly different than if we use fresh sperm. And in fact, many centers recommend, hey, let's freeze sperm as a backup just in case there's an emergency, or maybe the partner is unable to come the day of the egg retrieval, or maybe just in case the day of the egg retrieval, able to produce a sperm, we still have that frozen backup. So success with frozen sperm with IVF is just as successful as fresh. Another question that we received is, what are considerations for IVF with polycystic ovary syndrome? So probably the biggest thing with polycystic ovary syndrome is response and the risk for ovarian hyperstimulation syndrome. Hyperstimulation syndrome is a risk that can occur when the ovaries over-respond to the injection to stimulate them. In women with polycystic ovary syndrome, there can often be a fine line between recruiting a good, healthy number of eggs that we can see to recruiting so many eggs that now we have shifted into this risk for OHSS. And should a woman develop OHSS, essentially what happens clinically is that fluid inside your vessels goes to areas it's not supposed to be, like around your heart, around your lung, abdomen. It is a self-limiting condition. So, it happens and then you get better. But the risk here, however, is that fluid is spilling out of your venture. There is a higher chance for getting a clot in the legs and the lungs, potentially. And so it's definitely a risk that we take very seriously. And women with polycystic ovary syndrome, unfortunately, are at risk for developing that hyperstimulation syndrome. So your fertility provider is very thoughtful in designing the program for you to minimize this risk, but still, balance that with the chance for pregnancy. There are a lot of different that we can use to help to minimize the risk besides just being thoughtful about the protocol. More frequent monitoring, potentially changing the types of medication at the end of the stimulation just before the retrieval. And perhaps the most important intervention is not pregnant right away. So what that meaning, not doing a fresh embryo transfer. So for any woman who we are suspicious develop ovarian hyperstimulation syndrome, we can still do a retrieval, we can still get eggs out, we can still fertilize those eggs, make embryos, but in conventional IVF, where we're putting an embryo back in 5 days after the retrieval, if we think you're gonna have OHSS, the safest thing, we just freeze the embryos, we let your body recover, we let you recover, and then we do a frozen embryo transfer the next cycle. The added benefit of that, especially for women with polycystic ovary syndrome, even if we disregard the risk for hyperstimulation syndrome, chances for pregnancy with a frozen embryo transfer seem to be higher than with a fresh embryo transfer, again, in the setting of polycystic ovaries. So having said so much about IVF, and I think many on this Zoom meeting, maybe perhaps there are some folks outside of Illinois who are thinking about pursuing fertility treatments, is what risks in terms of insurance might we experience that could interrupt or derail care? And I mentioned before, fertility treatment is not just, an emotional and physical investment. For men, it's a financial investment. And, we as fertility providers, and I think in general, as a medical community, understand that fertility is a medical diagnosis, and there is a medical necessity to treat the underlying diagnosis. And actually, this Zoom meeting couldn't fall on a better day, because today is World Advocacy Day, or the National Advocacy Day for treatments. There are representatives across the country, fertility providers just like me, that are calling our state representatives to try for coverage on a broader scale. Right now, there are only about 16 states in the country that have some mandated coverage for fertility testing and treatment. And it looks different for each state. But for Illinois, if you're a resident in Illinois and your employer is based in Illinois, and depending on the size of the company that you work for, your employer, you should have fertility treatment coverage. The amount of coverage and the amount of the number of cycles or treatments that would be covered, or even types of treatments that could can be individualized based on the policy, but we are all lucky, or if you live in Illinois, you're very, very lucky that in a state that has recognized that infertility is a medical diagnosis and really warrants treatment. Hopefully, in the next several years, there will be more than 16 states that agree with that same dogma. The other things, however, that are not typically covered by insurance, even if you live in a state that offers coverage for this type of, generally, egg freezing, unless you have a cancer diagnosis, is generally not covered by insurance. Testing of embryos, specifically testing the chromosome count for embryos, is typically not covered by insurance. But my sincere hope is that we are on a path where most, if not all, of this treatment will be covered very. So with that being said, I think that was the last question that was submitted for the registration. So I'm not sure if anyone has any questions that's on the call currently, or Michelle, if you have any other thoughts for things that we could continue to chat about.
Sure. So it was really two topics that came up. So one was, I think, in reference to some of the concerns over, your length of fertility and that kind of thing. And for, particularly for women over 35, but even under 35, when there's situations where it doesn't seem to be that your period is coming on time, which may be a new phenomenon. There's negative pregnancy tests, maybe some symptoms like hot flashes, nausea, that kind of thing. What are the concerns at that point of what that could mean?
So if meaning is if it's possible that we haven't quite had a positive pregnancy test?
Right.
Yeah. So this gets always tricky. If we look at pregnancy loss, and if we look at between a clinical pregnancy loss and a subclinical pregnancy loss, it's very different numbers. So for a young in her early 30s, the chances to have a miscarriage are somewhere between 5 and 10%, which is really low. As we get older, those chances for miscarriage do elevate, but that is not taking into consideration subclinical pregnancy loss. So clinical pregnancy loss is, we know we're pregnant, we had a positive pregnancy test, and then we started having bleeding, or we get to a point in pregnancy, we see a pregnancy inside the uterus, but then stops, or something else happens that unfortunately wouldn't allow for the pregnancy to continue to develop. Now, again, those clinically recognized losses happen in about 5 to 10% of young women, about 15% of women in their mid. But subclinical losses may comprise something more like 40% of all conceptions. Subclinical loss means a loss that before we're even able to detect the pregnancy with a urine test, with a blood test, or with an ultrasound. And so what that means is maybe sperm met the egg and we had fertilization in an early embryo, but then that embryo, didn't continue to develop. Or maybe embryo started to make its way into the uterus, but then it stopped migrating. Or maybe it started to implant, but this was still so early in its development, we wouldn't have been able to detect it in the blood or with urine, but then it stopped. So it's not uncommon, honestly, that I hear from women, I had these very strong symptoms, but I didn't have a positive pregnancy test. As a fertility provider, I still lock that back in my brain as, could there something else going on that's leading to these subclinical losses? Maybe, we don't know whether or not they were true losses. How the evaluation for recurrent pregnancy loss is typically recommended if we've had 2 clinically recognized pregnancies that have been lost.
Okay, thank you. And then the other question had to do with situations where the male is not producing any sperm, and that could be higher FSH levels, and what treatments are, and if vitamins, like I know you talked about CoQ10, but if it's CoQ10 or other vitamins help in that.
Right. So if a semen analysis shows there's no sperm, the main thing that we look at is what is the volume of the ejaculate. So if the volume of the ejaculate is really small and there's no sperm, maybe it's because of an obstruction. There's a blockage. So maybe that man is making sperm, it's just not getting out to where it needs to be. In that scenario, certainly the blood work that would be recommended, we look at those hormones, similar to women having hormones that drive egg production, men have hormones that drive sperm production. So aside from a physical exam to see in this scenario, is that low volume ejaculate because of an obstruction? You can tell this with an exam. We also look at those hormone levels to just make sure that access, that talk back between and the brain are still working, because that would really suggest that that sperm is continuously still being made, just not coming out. So if it's a low volume ejaculate and we think it's because of an obstruction, it's a matter of that man going to a fertility specialist to assess where is the level of the obstruction. One cause for a low volume absence of sperm, what we call low volume azoospermia, is something genetic. It's called congenital bilateral absence of the vas deferens. It's seen mostly in men that have potentially even a cystic fibrosis mutation. So maybe they're a carrier for cystic fibrosis. And that mutation can actually cause an elevated chance for having this CBAVD. So making a lot of sperm, they just don't have the tube that goes from the testicle to urethra to deliver the sperm in the ejaculate. And in this scenario, the treatment is just identifying where's the level of obstruction, going proximal to that, taking sperm out with epididymal sperm procedures, and then utilizing that with fertility treatment. Not when we're doing a sperm retrieval procedure, depending on the amount of sperm we're able to get and what the diagnosis is, we may recommend IVF, sometimes IUI. Now the scenario, however, is very different for as normal volume ejaculate. Is it possible there could still be obstruction? It's possible, but in a man with normal volume now we start thinking about what else is going on that we're not seeing sperm in the ejaculate. And here again is where those back from the pituitary gland, the follicle stimulating hormone, can be a really important diagnostic factor. If the follicle is really high, what that's telling us essentially is that the stem cells that are making the sperm responding in the typical way. Now, sometimes if we follow those men that have very, very high follicle stimulant levels, sometimes we do see, and I've had at least one couple where this has been the case, we saw no sperm and a very high FSH level. 3 months, this man was quite ill. And we followed that man over the course of, actually it ended up being 6 months, the FSH normalized and he started making sperm again. But the real worry, however, is that if FSH levels are very high, is a sign of andropause. So similar to women that go through menopause earlier in life, is the lack of available because of something like andropause. Still here, sometimes urologic specialists might say, let's see if sperm in the testicles, and that would require micro epididymal or microtecture where they, under anesthesia, will actually look for sperm in the testicle. In those scenarios, almost excludes that sperm for IVF. And then, sometimes, unfortunately, even with looking for sperm in the testicles in the scenario, and any viable ones to use for fertility treatments. Unfortunately, if a man is an andropause, and this is the cause for not seeing in the ejaculate, there's no supplement or medication that can help recover that in the ejaculate. There are medications and treatments that we can use for men for whom that axis is still intact, so the pituitary testicle are still talking back to each other in the kind of a normal fashion. If we see low numbers of sperm, sometimes we can use the pill Clomid that we give for women to boost those sperm numbers. There's also a really rare condition where maybe don't make the hormone, that follicle stimulating hormone that drives sperm production. Very similar to how we had discussed, don't make that hormone, we just give that hormone back in the form of an injection. We can actually do the same thing for men as well. So if they're not making those hormones, that follicle hormone or luteinizing hormone, we can give them injections back to make sperm grow. So essentially, if we see a semen analysis sperm, we look at the volume of the ejaculate, we look at those same hormones that the to the testicle to recruit this to make sperm, and then we use those two pieces of information to decide, will fertility pills, will fertility injections for the man help to recover sperm production? Is there something else going on genetically that man into having andropause? Or is there an obstruction that may just need to be relieved that would allow us to recover sperm?
And when you talk about the medications and everything, we're not, you know what, actually, I just realized you answered the next question. So never mind. This is what Dr. Nayak does all the time, right? You have like another question building up and then she's already answered it. So never mind. I think that was it in terms of questions, unless anybody else had anything. I want to really thank Dr. Nayak. I've been through this all and I thought, oh, this is going to be boring for me. And 5 minutes in, I was like, oh, I've already learned something else. So I hope everybody else found this like super helpful. And I would just say, anything you can do, you can always find out more about us. We would love to hear stories and more questions. I know that Dr. Nayak is a great resource, and if we can use her again for a more specific topic, if there's interest in something, we're happy to do that as well. So I just want to thank everyone for coming. We'd always love to hear from you, and really a big thanks to Dr. Nayak and Reproductive Medicine Institute.
Thank you so much for having me. It's always so nice to see your face, and I hope to get to see you soon.
Yes, thank you so much.
Okay, guys, take care, stay safe.
Bye-bye. And